first presentation will feature a subgroup analysis from a phase 3 trial investigating everolimus for the treatment of neuroendocrine tumors of the gastrointestinal tract and unknown primary. Dr. Simron Singh, a medical oncologist at Sunnybrook's Odette Cancer Center in Toronto, Canada, will present the findings.
Thank you very much. So I'm here today to share with you the results of one of the largest ever conducted trials in neuroendocrine cancer called the RADIANT-4 trial, which looked at the role of the drug everolimus in advanced, progressive, non-functional neuroendocrine tumors of the GI tract as well as the unknown primary. As mentioned, this is a subgroup analysis of the very larger RADIANT program. Next slide, please. So neuroendocrine tumors, as many people are unaware, are a group of heterogeneous tumors arising from neuroendocrine cells that can really arise from anywhere in the body. However, neuroendocrine tumors of the gastrointestinal tract constitute approximately 60% of all neuroendocrine tumors, and they have very limited treatment options. As I mentioned, RADIANT-4 study was the largest completed multi-center phase 3 double-blinded randomized placebo-controlled study in patients with advanced non-functional lung or GI tract NETs. The results of the larger combined population showed that everolimus, which is an mTOR inhibitor, improved the median progression-free survival or time to tumor growth by 7.1 months compared to the placebo. This presented with a hazard ratio of 0.48, which is quite an astounding finding in cancer studies. The present analysis of the RADIANT-4 study looks in detail into the GI or gastrointestinal subgroup of these patients. Next slide. So this is the trial design. The patients with well-differentiated advanced progressive neuroendocrine tumors of both the lung or GI origin were randomized to receive either everolimus or placebo. It was a 2-to-1 randomization, which means that for every 2 patients that received everolimus, 1 patient received placebo. You can see here the majority of patients came from the gastrointestinal and unknown primary type subgroups. The endpoint of the study was progression-free survival. The study also looked at overall survival and a number of quality of life factors. Next study, please. The key results. Out of the 302 patients on the trial, 175 of these patients had gastrointestinal NETs, and 36 of them had NETs of unknown primary, which were generally thought to be part of the GI system. When we look at the GI patients, everolimus showed a mean progression-free survival of 13.1 months versus 5.4 months in the placebo arm. So clearly there was a significant improvement in stopping the tumor from growing when the patients received everolimus. When we looked at the unknown primary subgroup, the median progression-free survival was 13.6 months compared to 7.5 months in the placebo arm. Again, what we see here is a significant delay in the tumor's growth by treatment with everolimus. Next slide, please. So generally when we talk about neuroendocrine tumors, people often refer to the midgut or small bowel or carcinoid, and these are common terms that are used because this is a common spot of where these tumors arise from. For the purpose of the study, we define midgut neuroendocrine tumors to include primary tumors originated in the ileum, jejunum, cecum, duodenum, appendix, and small intestine. When we looked at the midgut patients, we see very clearly by these graphs that there was a benefit for everolimus. There was a 29% reduction in the relative risk of progression or death and a median improvement in progression-free survival of 6.41 months with everolimus as compared to those patients who did not receive everolimus. When we look at the non-midgut patients, so those patients who had tumors originating in the stomach, the colon, or the rectum, those patients saw a 73% reduction in the relative risk of progression or death and an improvement in their progression-free survival of 6.17 months with everolimus versus those patients who received placebo. Next slide, please. With the lack of treatment options for these tumors, many times we have been treating these tumors with somatostatin analogs. This trial had patients both who had been treated with somatostatin analogs and those who had not. What was interesting about this trial is it showed, regardless of whether the patient had been pre-treated or not, that everolimus seemed to be an effective therapy for patients. In the prior somatostatin arm, there was a 46% reduction in the relative risk of progression or death, with a median progression-free survival of 6.73 months versus placebo. And in those patients who had never been treated before, or what we would call treatment naive, there was still a 48% reduction in the relative risk of progression or death, with a median progression-free survival of over 9 months in those patients treated with everolimus versus placebo. So regardless of the prior treatment, the patients appeared to benefit from everolimus across the board. Next slide, please. These are the adverse drug reactions. And everolimus has been used previously in both kidney cancer and breast cancer, so we do have data, and this data was not surprising. This showed the typical type of side effects that we see with everolimus and that we're comfortable with managing in many cases. Those include stomatitis, which is mouth inflammation or inflammation of the mouth or sores, diarrhea, infections, and some fatigue. So this was all data that was previously understood. Next slide, please. So in summary, when we look at the RADIANT-4 data, we showed that everolimus improved progression-free survival in both the GI and the net of unknown primary subgroups. Everolimus improved the median progression-free survival in both midgut and non-midgut patients within the GI subgroup. And everolimus had a reduction in the relative risk of progression in patients who were both treated and not treated with somatostatin therapy before. The safety profile of everolimus was consistent with previous findings. No new safety signals or surprises were observed. And in my opinion, this study in advanced progressive neuroendocrine patients is an effective and new exciting treatment option in a disease where we've had very few treatments to date. Thank you.
Thank you, Dr. Singh. So, as you've discussed, the patients with the GI neuroendocrine tumors have had very little treatment options. Once they have progressed on somatostatin analogs, there really are no good systemic treatments. And so this finding is very important that the mTOR inhibitor everolimus has demonstrated an improvement in risk of progression by over 40% and with very little severe toxicity. So this is a welcome finding for these patients who've had limited systemic treatment options.